Welcome to the Eating Disorder Recovery Podcast.
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 Welcome to the Eating Disorder Recovery Podcast with me, Dr. Janine Anderson. Heads up, this show may contain adult language and may mention specific foods. If you find either of those to be too triggering, I trust you to take care of yourself and do what you need to do. This podcast is sponsored by Ipono Maui and ED Care. Ipono Maui is led by internationally renowned expert on eating disorders, Dr. Anita Johnston. Located in a home-like oceanfront facility in beautiful Maui, Hawaii, Ipono offers residential, partial hospitalization, and intensive outpatient treatment for eating disorders. Visit iponomaui.com, spelled AIPONOMAUI, to learn more. ED Care has provided PHP, IOP, and outpatient treatment for all genders 18 and over since 2001. CAMSA, which stands for Connection, Acceptance, Mindfulness, Sense of Self, and Action, is ED Care's mindfulness-based treatment approach and is incorporated into each individualized treatment plan. Facilities are located in Denver, Colorado Springs, and Kansas City, and all treatment is supported by master's-level clinicians or higher. ED Care offers 4 specialty tracks for binge eating disorder, elite athletes, substance use, and trauma. And the Connections House, an affordable supportive housing component, adds an extra layer of supervised support. Visit eatingdisorder.care or call 866-771-0861. Jennifer L. Gaudiani, MD, CEDS, FAED, is the founder and medical director of the Gaudiani Clinic. Board certified in internal medicine, she completed her undergraduate degree at Harvard, medical school at Boston University School of Medicine, and her internal medicine residency and chief residency at Yale. From 2008 to 2016, she was one of the leaders of the ACUTE Center for Eating Disorders at Denver Health. She left as its medical director to found the Gaudiani Clinic, which provides superb outpatient medical care to patients of all genders with eating disorders and disordered eating, and to those in recovery. The Gaudiani Clinic is a HAES-informed provider and embraces treating people of all shapes and sizes. Through a collaborative, communicative, multi-disciplinary approach, the clinic cares for the whole person in the context of their values. Dr. Gaudiani has lectured nationally and internationally, is widely published in the scientific literature as well as on blogs, and is a former board member of IADEP, the International Association of Eating Disorder Professionals. Dr. Gaudiani is one of the very few outpatient internists in the U.S. who carries the Certified Eating Disorder Specialist designation and is also a fellow in the Academy for Eating Disorders. You can find more information about Dr. Gaudiani at gaudianiclinic.com, linked in the show notes. Dr. Gaudiani, thanks for being here today. We're excited to talk with you about pregnancy and eating disorders.
Thank you so much for having me, Janine.
We're so excited to have you back. You're one of our favorite guests, definitely our favorite doctor for eating disorders.
Oh.
So tell us a little bit about the setup of how we're going to walk through talking about this topic, pregnancy, eating disorders.
I would love to. And it's important to start out by saying in all humility that as a non-therapist, I'll be discussing this from the internal medicine perspective. Mm-hmm. So very reasonably, there are a lot of key therapeutic concepts that I'm not going to cover today because I utterly and completely lack the expertise. Mm-hmm. But from my internal medicine perspective, what I'd like to talk about is the effect of a current or prior eating disorder on fertility, probably starting a little bit with what happens to female cycles of fertility well before there's any interest in pregnancy. Then I'd like to turn to the effect that eating disorders have on pregnancy outcomes, and then flip it and ask what impact pregnancy has on eating disorder outcomes.
I love it. Let's go for it. And then also, you have a book coming out. Tell us about the book. Tell us the title. Everybody can get excited to go buy it.
Oh, thank you so much. I'm still writing it right now. The book is called Sick Enough, a guide to the medical complications of eating disorders. It's going to be published by Routledge, and I'm not sure when it will be out, but it is a book really written for patients and their families, as well as eating disorder clinicians, to share with them my body of knowledge about what happens to bodies as a result of eating disorders, so that people can have a source of information that's not the often misleading Dr. Google.
Right. Dr. Google is pretty dangerous and scary.
Yeah.
So if you are listening to this and you love what Dr. G is saying, get excited, and I will keep you all posted about when her book does come out, because this is based on one of the chapters that you're writing for the book.
That's right. Thanks, Janine.
So tell us about fertility even before somebody maybe even considers becoming pregnant.
Great. So let's go back to my favorite trope of the cave person brain.
Love it.
The cave person brain is that part of our brain that runs us as a mammal. It's focusing on what's happening in our environment and has no idea that it's 2018 and that there are pressures on people or that there are stresses. It just understands what's happening to us as a mammal. And with regards to this particular topic, when somebody is malnourished, and we know that malnourishment can occur in bodies of any shape and size, sometimes the cave person brain, in the right genetic setup, says, uh-oh, my mammal's not doing well. It's certainly not a good time to expend precious and apparently sparse calories on reproduction. So here's how we're going to save my mammal some calories. A, in the part of the brain called the hypothalamus, we're going to stop calling out for sex hormones to be made. And that's mostly estrogen in females and mostly testosterone in males. We're going to, as a result, really drop the sex drive, because sex drive does burn calories. And we're also, in females, going to stop the entire process of menstrual blood loss, because we want to hold on to every body resource we can, as well as ovulation, because this mammal is not safe to get pregnant right now.
So this is protective mechanism by your body trying to just keep the necessary things on board before it can even consider adding another life form in the mix.
That's exactly right. And every time I talk about this, I am filled with wonder all over again at how much smarter our bodies are than we are. There's no number of 4 foods you shouldn't eat or 3 things to do this weekend that are possibly wiser than the many, many years of evolution we've gone through to protect us from the elements and, as it turns out, from our own worst instincts. So now we have somebody who's malnourished and their hypothalamus has gone quiet. I should pause and say, increasingly, the literature is showing us that females menstruate over a total bell curve of medical health and body weight. That is, it used to be thought that if you were so-called sick enough from your anorexia nervosa, you'd stop menstruating. It turns out that's wrong. So much of what we think we know in medicine, we wait a little longer, more information is gathered, and we realize we have a more complex situation on our hands. Because I have patients who continue to menstruate even when their eating disorder is ravaging them. And I have patients who haven't yet resumed a period after 2 years of fabulous self-care and wonderful nutritional status. And both parties are quite miserable, because the one who's been in her eating disorder feels like, oh my gosh, I'm so sick, and yet apparently I'm not sick enough, or I'd stop my period. And the one who's been taking care of herself miserably wonders if something's now permanently broken.
Oh gosh.
So periods happen over a wide spectrum, but we're going to talk about the folks for whom, in malnutrition, their brains stop producing the hormones needed to cause a period and to cause regular ovulation. Now, not to leave the males out of it, I should take a moment and say that when testosterone levels fall in males, sex drive falls, the ability to have spontaneous erections decrease, and the ability to have sort of a more normal, fulfilling sex life decreases. That's, again, the body sparing calories. And it's so important that physicians ask their male patients, can you tell me when or if you felt like your testosterone really fell below the reasonable level? And a lot of guys can name it practically to the week.
Wow.
And we test the testosterone and we can replace it. So for females who have eating disorders, it's not just underweight, of course, or classic malnutrition at any body weight that can cause menstrual irregularities. Females can be exposed to any number of things that any human who doesn't have an eating disorder might experience that causes ovulatory problems or fertility issues. I'm not going to go into those because we got enough. We got enough to talk about. But there's no doubt that the stress of an eating disorder at any body weight, in patients with binge eating disorder, in patients with bulimia nervosa, with atypical eating disorders, all of them can affect their menstrual cycle. And so we end up with a situation where we say, okay, what are the data? And the data turn out to be that we have to first assess what the data are. Where are we getting our information from?
Always a great question.
Yeah, we have to question it. There are two main sources around the topic of fertility and eating disorders. One set of data comes from population-based studies. That is, all of the pregnant women in a particular city are interviewed during their pregnancy and asked a ton of questions about their health, mental and physical, and then outcomes are studied. And of course, because that's from the population, just any person walking in, likely these are folks who, if they do have eating disorder symptoms presently, may have milder symptoms. Maybe they didn't get access to treatment, but in general, they may have milder symptoms. And we have to interpret the data accordingly. The other set of data comes from eating disorder programs who have kept track of all the patients that have needed at least one inpatient stay, and then they follow the patient's outcomes over the years. And by definition, because those patients were sick enough, as it were, in that country to require inpatient care, potentially their eating disorders might have caused more harm to the body. There might have been more psychopathology. Hard to say. But in general, studies emanating from eating disorder programs are going to represent somewhat of a more severe eating disorder history.
Right.
And might have different outcomes than the population studies.
That makes sense.
Great. So it turns out that a lot of my patients ask me, Dr. G, when I'm recovered from my eating disorder, can I get pregnant? And I'm so joyful to be able to say to them, yes, as much as any woman can expect to hope to get pregnant. Because infertility happens. Unfortunately, and as a feminist, this particularly bothers me, many of my patients in the adolescence of their eating disorders received threatening commentary from a physician who would say, if you keep this up, you're never going to be able to have a baby. And I mean, it is so inappropriate to foist the shame and blame game on women. That is absolutely unacceptable. So if that has ever happened to one of your listeners, may I offer you an apology on behalf of my entire profession. At the same time, those messages are often given when patients haven't the faintest interest in getting pregnant anyway, and so it's totally useless besides being mean. But the comment sticks.
Sure. And it makes it really scary instead of something where I'd imagine you'd want to be knowledgeable about the realistic implications of the ED on pregnancy, but also hopeful. Hope is so much more helpful than, and we actually know from the literature now, shame is not effective.
What a concept.
I know, right? One that makes intuitive sense and then is also supported by research.
Yeah.
That's a sweet spot for me.
That's a great sweet spot. So the answer is that yes, if you have had a history of an eating disorder and you fully recover, you have as good a reason to be able to get pregnant as anybody else. But there's some really interesting studies that look at people who aren't recovered, who are still in their eating disorder to some form or another. And a big study, a population-based study, evaluated a bunch of women who were pregnant and asked about whether presently or in the prior 6 months, women had experienced the following set of eating disorder symptoms. And it turned out that those with bulimia nervosa, presently or in the recent past, will be for all of these, had about twice the odds of having undergone fertility treatment. And those with anorexia nervosa had half of the pregnancy rate of controls without eating disorders. Even more stunningly, in a private fertility clinic study that did a questionnaire with all of its patients, 20% of patients attending this private fertility clinic met the criteria for an eating disorder.
It's heartbreaking.
And 0 of them had told their doctor.
I also wonder too, because I've heard about that in consultations and sort of things that I've done with other people's patients, and I've also heard that people don't get screened, which, I mean, if you're going through this, we'd really encourage you to bring this up with your doctor. Maybe we can give you some tips on how to do that from an empowering place, because it's really important information for them to have. But also, it would be lovely knowing that that statistic is so high to have some sort of screen and question in place.
Yeah, that's so right.
But 20%, 1 in 5?
1 in 5 in this fertility clinic. So what does that mean? Well, there's a couple implications. One, if you look from the physician's perspective, both OBGYNs in America and fertility specialists in Australia and New Zealand agree across the board that knowledge about eating disorders is important and that they lack that knowledge and training.
Cool.
Yeah, great. So we're sending patients right into the wilderness. But at the very least, I think that to the extent that the eating disorder permits one to come forward and say, even I'm not sure if I've got an eating disorder, but I've got a lot of food rules and a lot of exercise rules and a lot of body rules and number rules. I wonder if that's influencing my struggles with fertility right now. And if the physician says, I don't know, but why don't we put this on pause and get you a team and a therapist and really work on this, that's sometimes the best we can hope for. Even if that doctor doesn't have like a, well, I have a way of dealing with this. At least trying to bring it up is really important. On the other hand, this shows another example of weight bias and weight stigma in our society, that when patients who are in an eating disorder, and sometimes these are patients who are at a lower body weight, present for fertility assistance, the first thing the doctor says isn't, let's have a conversation about your feelings about food and movement and body, and do you have a history of an eating disorder? The first thing the physician may say is, all right, we're going to run the tests, we'll do this and that, and then we'll start you on fertility treatments. Because society's weight bias prevents us from being able to say that someone who appears aesthetically appropriate to our bizarre society in terms of thin focus, they're not realizing that the person's unhealthy.
Right.
Once again, size is being equated with health, which is not scientific.
Yeah, and dangerous.
And dangerous. And we see that stigma affects people on both sides of the size spectrum. So the other thing to think about with fertility is this, that even if a patient's period has been absent for months, I like to say that eggs happen. Every now and then, a woman will ovulate. And in the study that I cited, the big population-based study, the patients with anorexia nervosa who did become pregnant, 55% of those pregnancies were surprise pregnancies. That's double the typical population.
Wow.
So if a woman is having intercourse with a man and does not want to get pregnant, she should use protection. She should use birth control. And it's just important to remember that amenorrhea, or lack of the menstrual period, does not form adequate birth control.
Right. So you never know when it's going to resume, or you're going to have a surprise ovulation, and ovulation can be irregular whether you have an eating disorder or not.
That's exactly right.
Great point.
Yeah, that's exactly right. So I think the sum points are, eating disorders are interpreted by our cave people brain as my mammal is not well, and the body will do what it can to try to prevent pregnancy until body and soul are in a better place, that society's weight bias may fail to identify patients who seek to get pregnant while still in the midst of an eating disorder, and that once you really recover from an eating disorder, your fertility should be unimpeded. And that's really a hopeful, optimistic note for people out there.
Right, probably really comforting for a lot of people listening.
I hope so. So then we turn to how do eating disorders influence pregnancy outcomes? And there have been a couple of really big, helpful studies. One of them was from an eating disorder program in Sweden. And again, here's where we would expect potentially that the outcomes are a little more extreme than in a population study. But they found that across all of the eating disorders, pregnancy and childbirth rates were lower than those of controls. Not for people trying to get pregnant, but presumably because not everybody got to a stage of recovery where they wanted to or where that was an option.
Right.
The highest rates of miscarriage were in those with binge eating disorder, and almost half of pregnancies in those with binge eating disorder ended in miscarriage, as opposed to about 17% of the average population.
Wow.
And then infertility treatment in that study was sought by 7% of patients with eating disorders, as opposed to 4.5% of controls, so about double the rate of infertility seeking.
Do we have many data or theories as to why those numbers are the way they are, or we just kind of have the descriptive stat at this?
I think we have the descriptive stat.
Gotcha.
One could posit it, but I think potentially one could fall into one's own biases in wondering where that comes from.
Sure.
It turns out that as far as pregnancy outcomes, when patients who have anorexia nervosa become pregnant, they're more likely to deliver babies that are abnormally small. And that's called intrauterine growth retardation, or IUGR. By contrast, patients with binge eating disorder often have babies that are larger. The reason for that may be that in those who have insulin resistance and who make more insulin, that insulin actually crosses the placenta and acts as a growth hormone on the baby.
Oh.
And you would think, like, great, a big baby. But it turns out that delivering big babies can be harder, and there can be more complications in delivery. Mm-hmm. Twin births are more prevalent across all eating disorders because they're seeking more fertility treatment.
Okay, that makes sense.
And the good news is, for those who have recovered from anorexia nervosa, the risk for gestational age babies goes away if mom gains enough weight during the pregnancy.
Okay.
In addition, the patients who have ever had a higher level of care for eating disorders seem to have higher complications at birth, a higher risk of a C-section rate or a higher risk of premature delivery, and that's not seen in the population-based studies.
Right.
The overall message is that it's better not to get pregnant when you actively have an eating disorder. I don't want to state the obvious, but pregnancy is tough. Motherhood is tougher. And the recommendation would be seek out your own recovery, seek out your own wellness, physical and emotional, before you become responsible for someone else in that way. Mm-hmm. It's safer for mama, it's safer for baby.
Yep.
So then let's flip it. How does pregnancy influence eating disorders? So there was this great study called the Norwegian Mother and Child Cohort Study that was the first large population study from the general community to evaluate the peripartum effect, meaning before and after the birth of a child, effect on eating disorders. And they looked for patients who were pregnant and currently had an eating disorder or had one within 6 months of getting pregnant. They found that women with an eating disorder gained more weight during pregnancy, which was certainly necessary for those with anorexia nervosa who started at a lower body weight. They worried more about their shape and size, and they had higher rates of postpartum depression than women without eating disorders. The good news is that eating disorder thinking and behaviors often radically improves during pregnancy and may go away completely Patients who for years have struggled to combat behaviors when they become pregnant can be amazed at what they can require themselves to do as far as rest and nutrition on behalf of their baby.
Mm-hmm. And even weight gain, which is a lot of eating disorders' worst fears, and it is, body dysmorphia is really difficult to deal with in general, but I've certainly worked with patients who, when pregnant, that really went down for them, and they were really connected to the baby and the idea of becoming a mother, and were able to get through the tougher moments of that, knowing that it was also for this other little person.
Yeah, that's exactly right. That's been my experience as well. The one risk to it is that it can lull patients already on the side of I'm fine into thinking they no longer need their team. Mm-hmm. I'm pregnant, I'm doing great, I've got everything I always wanted, I'm not doing behaviors, I don't even think that way anymore. I think I'm good. Mm-hmm. And they can back out of that vital support that their therapist and their dietitian may be providing if they're still on the tail end of the recovery process, much less in the midst of their eating disorder.
Sure.
It's so easy for eating disorders to taunt patients into thinking you're fine.
Right.
Which is the reason that I'm writing my book, because the idea is that patients are sick enough to seek care and recovery. So then the question is, what happens sort of right after pregnancy? How does this honeymoon period go with regards to that tender, loving care of body? Unfortunately, it showed that 18 months after delivery, so with a 1.5-year-old running around the house, only 50% of patients with anorexia and 40% of patients with bulimia were still in recovery. And then at 36 months after delivery, so with a 3-year-old running around, 60% of patients with anorexia and 30% of patients with bulimia were in recovery. And these, of course, are for patients who were in their disorder during pregnancy when they were first studied, not somebody who had been well for years before getting pregnant. But that's really significant. That means that not only does somebody now have a child to be raising, but they're back in their own disorder.
Right.
We know how distracting and all-consuming eating disorders can be.
Right. And I can't even tell you. So I'll just identify this and put this out there on the podcast. At the time of this recording, I'm not a mother. I've never been pregnant. However, I've worked with a bunch of clients or, talked to podcast listeners about this, and mom guilt is a real thing. And I think for the people I've spoken with who are still working through their eating disorder after they have a baby, it can serve as this additional layer of shame and guilt, like, oh my gosh, I have this beautiful child and I still can't do it. I can't get it together. I still have this eating disorder, and it can be so frustrating and awful. Mm-hmm. So if you're thinking about that as we're having this discussion, I'd really encourage you to try to be compassionate, because there are so many things that go on with having a baby in general, let alone having a baby and you have eating disorder stuff going on in your life. I can't even imagine how many stressors that is to deal with all at once.
Yeah, that's so compassionate. I think as feminists, as professionals in this field, and just as women in the world, we have to offer each other every opportunity to give what my best friend calls a gold star for relaxation and for self-care. She's like, I'm not going to gold star you when you do something impressive. I'm only going to gold star you when you slow down and take it easy. We all have to do that for each other.
Yeah.
There are opportunities when I take care of patients in their eating disorder who are mamas to bring a new depth to the conversation. And of course, I'm not a therapist, but I try to bring in motivation as I offer people evidence of objective body suffering by means of helping them move forward in recovery. And as much as anything, through that mom guilt, it's really important to remember what you're modeling for your child in terms of what you want them to absorb about lessons of self-care. And just to take a quick detour, it's so important, I like to remind my patients that self-care is not conditional. You don't do self-care at the end of your checklist when everything else is taken care of, because the checklist is never done.
Oh my gosh.
And so if we're going to show our children a model, not always the best model, but it's the model that they've got in their given parent for how we hope they'll care for themselves, we too have to hold still. We too have to put our feet up with a swarm of things dancing in our heads that need to get done and just say, let's cuddle. And my girls are now 9 and 12, and the closer they get to young womanhood, the more and more I think about these things.
Yeah. I'm thinking about a lovely woman I worked with in therapy who really just had such intense feelings of guilt about still wrestling with her eating disorder and having a young child. I think he was under 4 by the time we were working together. And she felt so terribly that she was still dealing with it. And my reframe to try to be more gentle with it is, if you can think about doing recovery as a way to model working towards something, your kid may not be asking you to have perfect recovery, but by doing all the things, all the tough work of recovery that you are engaging with, you're showing this little guy that you're trying, and you show this little guy that you are healing. And I feel like that's so much more of a hopeful thing to go after, instead of getting caught in the guilt and potentially even saying, I can't do it, I'm going to have to give up. It's all over because I haven't gotten rid of it at this point.
Yeah, that's so strong and so healing. Totally agree with that. I think the last piece of data that I'd like to share on the topic of how pregnancy can influence eating disorders is that a Swedish study looked at, again, patients who had ever been admitted. And interestingly, the 63% of women who never got pregnant and bore a child accounted for 86% of deaths in the cohort. The idea isn't that pregnancy saves lives. It's that it can be a marker of a certain degree of recovery. And those patients who choose not to have children, that is fantastic and worthy and appropriate. And those who wish they could have and weren't able to, that is also to be given compassion and support. But it's an interesting statistic. And furthermore, childbearing decreased mortality by over 60%. So the idea is that if a woman was able to get into a good enough place of recovery, that she found a partner, she got pregnant, she delivered a child, that was a good marker. So I think as I wrap up the whole picture, it's worthy to keep working on recovery. Full, complete recovery. And then, if you so choose, and everyone chooses differently, you have the opportunity to engage in the biological prerogative of women if you happen to be able to, like anybody else. And that recognizing the barrage that society aims at women and their bodies around the time of pregnancy and postpartum is so very important, because as a dear friend of mine just mentioned to me, and I will be quoting her without the original one, you can tell someone all day long for them to love their bodies, but if they walk out into a society that tells them they're hated, they're not going to be well served. And so I think when I work with patients around body image and pregnancy, it's important to say society is toxic. You know, when I was pregnant, not having had an eating disorder, in the same day, strangers or people I was professionally vaguely associated with felt perfectly fine to tell me I was huge or tiny.
Oh my gosh.
And of course the same day, just depending on how they felt about how my appearance looked, or to lay hands on me. And I thought to myself, well, this is ridiculous.
It is ridiculous.
And if I had an eating disorder, it would be harmful.
Oh my gosh.
So we have to prepare people for that reality, that eventuality, and maybe arm them with how they can deflect those comments or process them afterwards. And then the media's favorite magazine cover is to tell you, quote unquote, who got their body back, after pregnancy.
As if it ever left them. And as if it shouldn't change if you grow a freaking human being inside you.
Exactly.
I was actually going to ask you about that because I'm just thinking about how much pressure there is now for women to lose the weight that they gain during pregnancy and have this pre-baby body. If you could speak to some of the potential medical reasons or body-based reasons why you should not pursue that anyway, but why it could be harmful to try to rush your body down to a lower weight. And I don't even know if everybody's body goes back to where it was before they have a baby.
Who would want it to? It's like saying, I want to go back to my pre-adolescent body. Nope. Women's bodies change during pregnancy. And everyone's body changes differently. Just like I wasn't born either with the genetic body type to be a runway model or to be an Olympic heavyweight lifter. So some people's bodies will look similar to before pregnancy at some point, and some will look radically different forever. The key is that that's natural. Mm-hmm. That is scientifically true. The line, the nonsense, the lie, really, that women are sold is that if they just have enough willpower or just buy the right products or just resist their hungers satisfactorily, they have a say on how that process goes. And that is just not true. Right. If someone is going to get stretch marks during pregnancy, they will get stretch marks no matter what kind of expensive lotions they rubbed on their tummies and bums. Mm-hmm. So women are constantly being sold this nonsense that we have control over things that in fact we don't.
And that we should try to control these things.
We shouldn't. Because it's stressful, expensive, and useless.
Yeah.
And harmful.
Disempowering, for sure.
And that's why I continue to believe so deeply in a health at every size philosophy, which covers all the things.
Love it.
Yeah, it covers all the things. And it covers how you nourish yourself and move during pregnancy. It covers how you nourish yourself and move and rest yourself after you have a baby. It reminds us about body diversity and about taking care of ourselves within our ability and according to our goals and values and not according to some externally imposed set of Western patriarchal values.
Right.
So the fact is that the dangers of losing weight too fast after pregnancy start with whether somebody chooses to breastfeed. That is a choice that people can make, and some people who choose it aren't able to. So I want to make sure that there's no judgment in what I say. But for someone who chooses to and is able to produce milk, losing weight too fast can prevent adequate milk production. And so you're literally depriving your child of biologically perfectly engineered food. And your body has to recover and stay strong and be allowed to do the work of changing from a vessel that carried a baby into its own human again. If you starve the body during that process, the muscles won't be as strong and healthy. Nothing about that process gets nourished. And so you're likelier to damage your body in the long term.
Right. And that's on top of all of the psychological side of you're greatly increasing the risk for relapse and onset of symptoms are getting a lot more severe. So we really want to be careful with that. And my recommendation is always that you get connected to a really truly recovery-focused community and rely on your treatment team, because that message that's out there, especially in the U.S., of you've got to get back to your pre-baby body, is so toxic and ridiculous. And you need to be grounded in people who do not think that way, who are not going to pathologize your normal body responses to having a baby.
That's completely right. And we all have agency in not accidentally contributing to these conversations or to somebody else's moment of harm. One of the things that I feel is that women often put ourselves down as a way of covering, because women are taught, don't think too highly of yourself, or don't get too full of yourself. And so accomplished women, when praised for something, can deflect it and then give themselves a piece of criticism as if to say, I'm not getting too full of myself. And so casual negative body talk or self-talk or appearance talk is so common amongst women casually, socially. Anybody listening, whether they have an eating disorder or never have, can avoid contributing to that talk.
Right.
They can never talk negatively about their bodies. If they have to talk about their bodies at all, they can avoid talking negatively about any particular type or group of food. They can avoid praising someone whose body has changed in a way that is appealing to some sort of media-informed, unrealistic ideal of femininity.
Right.
We can just not participate. And I think that's that recovery-informed community of women who have other things to talk about and care about than the appearance of their bodies.
Right. Absolutely.
I like to say, celebrate the things that you can't post a selfie on.
Ooh, I like that. That's good. I like that. One last quick thing I wanted to just ask you, and I know we could go into serious depth about this, I'm sure, but wanted to ask about what people can expect in terms of changes with digestion. That's normal during pregnancy, because we know if you have an eating disorder, a lot of the times digestive symptoms and sensations can be really triggering and difficult to deal with, and pregnancy, as part of its normal course, can have a lot of that involved. Could you give us a brief rundown of that?
Yeah, great question. I think if we talk about someone who has a long ago history of an eating disorder, their experience in pregnancy is likely to be that of any woman, which is highly variable.
Right.
So some women just waltz through pregnancy with not a blink. Just couldn't be easier. That's not the vast majority of us. Others will find that the challenges of morning sickness can bring back memories of purging days.
Right.
And give that little worried, wait, am I throwing up right now because I'm sick from my pregnancy? Or is there any part of this that's reawakening in me? Ugh, scary. And then I think that's very true for patients with an active eating disorder. You know, where is this my pregnancy? Where is this my eating disorder?
Right.
GI changes that involve constipation can be really challenging, whether you've had an eating disorder remotely or currently. But in general, a good OBGYN can kindly guide you through what's safe in order to make sure that you're pooping often enough for comfort and health, and not tempted to engage in more dangerous behaviors.
Right.
Along those lines, it reminds me that anyone with a history of an eating disorder can and should ask their doctor's office never to discuss their weight during the course of pregnancy, because weights are a part of normal pregnancy care. And it's best just to say, I had an eating disorder and I'm going to go back to the scale. I haven't seen my weight in years. I don't need to. I would really appreciate it if you not discuss my weight with me unless there is something markedly wrong.
Love
for
it.
A piece of little self-advocacy.
Yes, no, I think that's really helpful for people listening. And you can get blind weights done, meaning that you don't look at the scale and they make sure not to show it to you and not show it in your chart and on the screen and all of that stuff. I've always done that. I have no idea what my weight is, and it's fine.
Yeah, that's exactly right. I think the final thing with regards to GI is reflux. Acid reflux is really common in pregnancy. And again, for patients who have a history of rumination or who have a purging history or who just don't like the feeling of acid in their chest.
It's awful.
It's awful.
Yeah.
So, I think those are probably the commonest GI issues. And to the best of people's abilities, being able to communicate through those honestly with their doctor. And if their doctor is less than receptive, then with their therapist, not from a sort of fix my constipation perspective, but from a, can we talk about how this is making me feel to have these feelings in my body again?
Right. It's uncomfortable bodily sensations.
Yeah.
Yeah. And I'd also say if you're listening and you have any kind of concern or questions or wonder, I would say reach out to somebody and ask. There's no harm in asking the professionals about, the potential risks involved or where you're at in your recovery, or even if you've been recovered for a very long time. I've had clients who have started working with me who've been recovered for a long time, but they've become pregnant and they're very aware that their body is going to change drastically and they just want to be on top of it. And I think that is such a healthy way to advocate for yourself.
I strongly recommend that.
Yeah, there's no shame in reaching out for additional help, no matter where you are in recovery. Thank you so much for joining us and talking all about pregnancy and eating disorders. Really illuminating conversation, and I think people are going to find it more hopeful than maybe they would have expected, and hopefully we eliminated a lot of the fear-based talk that's out there about fertility and eating disorders especially.
It's always just an amazing pleasure and privilege to be able to speak with you.
Thank you so much.
Thanks.
Thanks for joining me for another episode. Let's keep in touch. You can find all the information you need about the podcast at eatingdisorderrecoverypodcast.com, including full podcast episodes and links to all of our social media sites. You can join our Facebook group for the podcast by searching Eating Disorder Recovery Podcast on Facebook. This is a closed group for listeners of the podcast looking to connect, share resources, and get involved in a pro-recovery community. Don't forget to subscribe to the podcast on iTunes, Stitcher, SoundCloud, or YouTube. Please leave us a review and let us know how we're doing. Talk to you next time on the Eating Disorder Recovery Podcast.